In this video, we will be covering myocardial infarction. Myocardial infarction refers to the process by which area of myocardial cells in the heart are permanently destroyed. Myocardial infarction occurs because of an abrupt stoppage of blood flow through a coronary artery due to thrombus formation, which is caused by platelet aggregation. This can lead to myocardial cell death, that is necrosis, in the heart muscle beyond the blockage. There are two types of myocardial infarction, ST elevation myocardial infarction and non-ST elevation myocardial infarction. Now we will see what causes myocardial infarction. Like unstable angina, MI is usually caused by reduced blood flow in a coronary artery due to atherosclerosis and occlusion of an artery by an embolus or thrombus. Because unstable angina and acute MI are considered to be the same process but different points along a continuum, the term acute coronary syndrome may be used for these diagnoses. Other causes include vasospasm of a coronary artery. It is a sudden constriction or narrowing of coronary artery. MI can be due to decreased blood supply from acute blood loss, anemia, or low blood pressure, or due to increased demand for oxygen from a rapid heart rate, thyrotoxicosis, or injection of cocaine. In each case, a profound imbalance exists between myocardial oxygen supply and demand. ST elevation MI is caused by an occlusive thrombus, results in ST elevation in the ECG leads facing the area of infarction. ST elevation is significant if it is 1 mm, that is one small block, or more above the isoelectric line in at least 2 contiguous leads. There, the ST elevation must be 2 mm or 2 small blocks or more. STEMI is an emergency. To limit the infarct size, the artery must be opened within 90 minutes of presentation to restore blood and oxygen to the heart muscle and limit the infarct size. If the patient does not see treatment quickly, the STEMI will evolve to cause potentially significant heart muscle damage. A pathological Q wave will be seen on the ECG if the patient does not seek immediate treatment. A pathological Q wave is just a deep Q wave or a Q wave that is greater than or equal to 1/3 the height of the R wave in the same lead. Non-ST elevation MI is caused by a non-occlusive thrombus. It does not cause ST segment elevation on the 12-lead ECG. The ECG may or may not show ST depression or T wave invasion in the leads facing the area of infarction. Non-ST elevation MI patients do not need an emergent catheterization but usually undergo catheterization within 12 to 72 hours. Now we will see the pathophysiology of myocardial infarction. Coronary occlusion, heart attack, and MI are terms used synonymously, but the preferred term is MI. The degree of collateral circulation influences the severity of the MI. Not everyone develops collateral circulation. What is collateral circulation? Collateral circulation is the alternative circulation around a blocked artery or vein via another path such as nearby minor vessels. A person with a long history of coronary artery disease may develop good collateral circulation to provide the tissue around the evolving infarction with an adequate blood supply. This is one reason a younger person may have a more serious first MI than an older person with the same degree of blockage. The area of infarction takes time to develop. Injury to the endothelial lining of the coronary arteries causes platelets, white blood cells, fibrin, and lipids to gather at the injured site. Foam cells or resident macrophages gather beneath the damaged lining and absorb oxidized cholesterol, forming a fatty streak that narrows the arterial lumen. As the arterial lumen narrows gradually, collateral circulation develops, which helps to maintain myocardial perfusion distal to the obstructed vessel lumen. The illustration shows collateral circulation. When myocardial demand for oxygen is more than the collateral circulation can supply, myocardial metabolism shifts from aerobic to anaerobic, producing lactic acid, which stimulates nerve endings. As the cells are deprived of oxygen, ischemia develops, cellular injury occurs, and over time, the lack of oxygen results in infarction or the death of cells. This decreases contractility, stroke volume, and blood pressure. Hypotension stimulates baroreceptors, which in turn stimulate the adrenal glands to release epinephrine and norepinephrine. These catecholamines increase heart rate and cause peripheral vasoconstriction, further increasing myocardial oxygen demand. Damaged cell membranes in the infarcted area allow intracellular contents into the vascular circulation. Because of that, ventricular arrhythmias then develop with elevated serum levels of potassium, creatine kinase, CKMP, aspartate, aminotransferase, and lactase dehydrogenase. All myocardial cells are capable of spontaneous depolarization and repolarization. But infarction or injury or ischemia affects the electrical conduction system. Extensive damage to the left ventricle may impair its ability to pump, allowing blood to back up into the left atrium and eventually into the pulmonary veins and capillaries. Crackles may be heard in the lungs on auscultation. Pulmonary artery wedge pressure is increased. As back pressure rises, fluid crosses the alveolar capillary membrane, impeding diffusion of oxygen and carbon dioxide. Arterial blood gas measurements may show decreased partial pressure of arterial oxygen and arterial pH and increased partial pressure of arterial carbon dioxide. MI results from prolonged ischemia to the myocardium with irreversible cell damage and muscle death. Functionally, MI causes reduced contractility with abnormal wall motion, altered left ventricular compliance, reduced stroke volume, reduced ejection fraction, elevated left ventricular and diastolic pressure. Most MIs affect left ventricle and are described based on the location of the damage to the left ventricular wall or to the right ventricle. Examples are anterior, inferior, lateral, septal, or posterior wall infarction, and at the point in time within the process of infarction, that is acute, evolving, or old. The acute MI process evolves over hours to a few days. The earliest tissue to become ischemic is the subendocardium, that is the innermost layer of tissue in the heart muscle. If ischemia persists, it takes around 4 to 6 hours for the entire thickness of the heart muscle to necrose. If the thrombus is not completely blocked in the artery, the time to complete necrosis may be as long as 12 hours. The degree of left ventricular dysfunction depends on the area of the heart involved and the size of the infarction. The location of the MI and ECG changes correlate with the involved coronary artery. For example, in most people, the right coronary artery supplies blood to the inferior and posterior LV walls. Blockage of the right coronary artery results in an inferior wall or posterior wall MI. Anterior wall infarction results from blockages in the left anterior descending artery. Blockages in the left circumflex artery usually causes lateral walls MIs. Damage can occur in more than one location, especially if more than one coronary artery is involved. For example, anterior lateral MI. Now we will see the clinical manifestations. Not everyone has classic symptoms. Chest pain with an MI is often worse than with the previous episodes of angina. Persistent, and unlike any other pain, it is usually described as a heavy pressure, tight, burning, constricted, or crushing feeling. Common locations of pain are substernal or epigastric area. The pain may radiate to the neck, lower jaw, and arms, or to the back. When epigastric pain is present, the patient may relate it to indigestion. Because of that, the patient may take antacid without any relief and therefore delay seeking treatment. Pain may occur while the patient is active or at rest, asleep, or awake. Pain often occurs in the early morning hours. It usually lasts for 20 minutes or longer. Some patients may not have pain but may have discomfort, weakness, nausea, indigestion, or shortness of breath. Some women may have atypical discomfort, shortness of breath, or fatigue. Patients with diabetic may have silent or asymptomatic MIs because of a cardiac neuropathy or have atypical symptoms like shortness of breath. An older patient may have a change in mental status, that is confusion, shortness of breath, pulmonary edema, dizziness, or dysarrhythmias. During the initial phase of MI, because of the sympathetic nervous system stimulation, the ischemic heart cells release catecholamines, that is epinephrine and norepinephrine. This results in diaphoresis, increased heart rate and BP, and vasoconstriction of peripheral blood vessels. Patient may also be anxious and restless. Their heart rate and respiratory rate may be faster than normal. These signs and symptoms, which are caused by stimulation of the sympathetic nervous system, may be present only for a short time or may not be present, or only some of them may occur. In many cases, the signs and symptoms of MI cannot be distinguished from those of unstable angina. Anxiety, restlessness, lightheadedness may indicate increased sympathetic stimulation or a decrease in contractility and cerebral oxygenation. The same symptoms may also herald cardiogenic shock. Headache, visual disturbances, altered speech, altered motor function, and further changes in level of consciousness may indicate cerebral bleeding if patient is receiving thrombolytic. What are the cardiovascular manifestations? Chest pain or discomfort, palpitations may be present. In response to the release of catecholamines, BP and heart rate may be high initially. Blood pressure may be elevated because of a sympathetic stimulation. Later, the BP may drop because of decreased contractility, decreased cardiac output, impending cardiogenic shock, or medications. If severe enough, this may result in decreased renal perfusion and urine output. If crack is present, it may persist for several hours to several days, suggesting LV dysfunction. Increased jugular venous distension may be seen if the MI has caused heart failure. So, jugular vein distension, hepatic engorgement, and peripheral edema may mean right ventricular dysfunction. Patient may have abnormal distant heart sounds. Other abnormal sounds suggesting LV dysfunction are S3 and S4. A loud hollow systolic murmur may occur with a ventricular septal defect or papillary muscle rupture, resulting in mitral regurgitation. Mitral regurgitation occurs when the valve does not close properly, allowing blood to leak back into the left atrium. Pulse deficit may indicate atrial fibrillation. In addition to ST segment and T-wave changes, ECG may show tachycardia, bradycardia, and dysarrhythmias. Patient may have gastrointestinal symptoms like nausea and vomiting. These symptoms can result from reflex stimulation of the vomiting center by the severe pain. They can also result from vasovagal reflexes initiated in the area of the infarcted heart muscle, especially with inferior wall MIs. Patient may develop respiratory symptoms like shortness of breath, that is called dyspnea, tachypnea, and crackles if MI has caused pulmonary congestion. Pulmonary edema may be present. Decreased urinary output may indicate cardiogenic shock. The patient's skin may be ashen, clammy, pale, and cool to touch, or have moist skin or diaphoretic due to sympathetic stimulation from loss of contractility may indicate cardiogenic shock. Dependent edema may also be present due to poor contractility. Patient may have a psychological symptoms like fear with feeling of impending doom, or patient may deny that anything is wrong in their life. The temperature may increase to 100.4 within 24 to 48 hours. Fever may last 4 to 5 days. This increase is due to systemic inflammatory process caused by the death of myocardial cells. How can we find out the patient is having MI? First test is electrocardiogram. The ECG is one of the primary tools to diagnose unstable angina or MI. Whenever is possible, we should compare a new ECG to a previous ECG. Changes in the QRS complex, ST segment, and T-wave caused by injury, ischemia, and infarction can develop slowly or quickly with unstable angina or MI. The pattern of ECG changes among the 12 leads provides information on the coronary artery involved in acute coronary syndrome. The ECG must be read carefully since changes can be absent or subtle at first. For this reason, we do serial 12-lead ECGs. For diagnostic and treatment purposes, it is important to distinguish between STEMI and non-STEMI or unstable angina. STEMI patients usually have a complete coronary occlusion and must go to the catheterization laboratory emergently. We will see ST elevation in the leads facing the infarcted wall on the 12-lead ECG. ST segment elevation is significant if it is 1 mm or more above the isoelectric line, 2 mm or more in V2 and V3 in at least 2 contiguous leads. Within a few hours to days, the ST segments begin to lower with the T wave invasion and the pathologic Q waves developing in the same leads if reperfusion is delayed or not done. The pathologic Q wave will remain on the ECG forever. With early reperfusion, Q waves may not develop. T wave invasion may persist for months after a STEMI. Patients with non-STEMI or unstable angina usually have a transient thrombosis or incomplete coronary occlusion. ECG changes with unstable angina or an non-STEMI include ST depression and T wave invasion in the leads facing the area of ischemia and infarction. Both groups may present with angina and have the same ECG changes. The only way to tell if the patient is having an non-STEMI or unstable angina is by drawing cardiac biomarkers. The biomarkers will be high in the non-STEMI patient but normal in the patient with unstable angina. Non-STEMI patients do not develop pathologic Q waves on the ECG. Because MI is a dynamic process that evolves over time, serial ECGs are done to show the evolution of ischemia, injury, infarction, and resolution of the infarction. Serial 12-lead ECG may show no abnormalities or may prove inconclusive during the first few hours after MI. When present, characteristic abnormalities on the ECG can help pinpoint the location of the MI. ST segment monitoring can also identify patients at high risk for reocclusion after percutaneous transluminal coronary angioplasty or MI and permits prompt intervention if reocclusion occurs. After MI, monitoring may reduce or eliminate the need for angiography in patients receiving thrombolytic drugs by gauging the efficacy of the drugs. Next tests include serum cardiac biomarkers. Serum cardiac marker measurements show elevated CK, especially the CK-MP isoenzyme, that is the cardiac muscle fraction of CK, thrombin I and T, and myoglobin. Serum cardiac biomarkers are proteins released into the blood from necrotic heart muscle after an MI. These biomarkers are important in the diagnosis of MI. The presence of biomarkers helps distinguish between unstable angina and non-STEMI. In unstable angina, the biomarkers will be negative, and non-STEMI, it will be positive. Cardiac-specific thrombin biomarkers are highly specific indicators of MI. There are two types, cardiac-specific thrombin T and cardiac-specific thrombin I. Serum levels of a cardiac-specific thrombin T and I increase 4 to 6 hours after the onset of MI. It will be peak at 10 to 24 hours and return to baseline over 10 to 14 days. Serial sets of conventional cardiac-specific thrombins are drawn over 24 hours. That means every 6 hours. CK levels begin to rise about 6 hours after an MI, peak at about 18 hours, and return to normal within 24 hours to 36 hours. The CK-MB band is specific to heart muscle cells and helps to quantify myocardial damage.